Welcome! We're diving into a high-yield update on the influenza virus, specifically for medical microbiologists. Now, all the information you're about to see was put together using a Gemini deep search, and if you want to see the full list of sources, they're all available in the linked Notebook LM document.
So let's start with the virus itself. You're looking at its basic structure, a helical nucleocapsid tucked inside a lipid envelope. And believe it or not, this very design is what makes it such a persistent global health challenge. It's built to change.
All right, here's our game plan. We're going to follow the story from the lab bench to the patient's bedside and then right back again. We'll cover its fundamental biology, the clinical impact, and of course, the absolutely crucial role the lab plays in how we respond.
Okay, let's get into the nitty-gritty, starting with the foundational virology.
So the virus is part of the Orthomyxoviridae family. Now, the four main genera you see here, they're classified based on really big antigenic differences in their internal proteins, the stable parts, like the nucleoprotein and matrix protein. That's our first level of sorting.
But here's where it gets really interesting. The subclassification, especially for influenza A, is all about the surface proteins, HA and NA. These are the parts our immune system sees and targets. And because they're so variable, this is how the virus is constantly changing its disguise to evade us.
And that leads us to two concepts that are absolutely critical to understand: drift and shift. You can think of it like this. Antigenic drift is the slow, steady accumulation of small changes. It's why we need a new flu shot every year. But antigenic shift, that's the big one. It's a sudden, dramatic change, a complete genetic reshuffling that can create a brand new virus, and that's what has the potential to cause a global pandemic. So if we zoom in on the virion, you see the envelope studded with those HA and NA proteins. But inside, there's a matrix protein layer holding it all together, and within that are the 8 separate RNA segments of its genome. This segmented nature is the key. It's exactly what allows for that dramatic genetic reassortment we see in antigenic shift.
All right, so let's shift gears from the virus's structure to what it actually does to people. We're moving from the bench to the bedside to see how this all translates into clinical disease.
A typical infection follows this timeline. The incubation period is pretty short, maybe 1 to 4 days. But look at day -1. Viral shedding often starts before the person even feels sick. And you know what that means? It's a huge factor in how efficiently this virus spreads through the community.
Now, for most people, it's a self-limiting, albeit miserable illness. But the real danger, the thing we're always watching for, is severe complications. The virus can cause a nasty primary viral pneumonia, but what's often just as deadly is secondary bacterial pneumonia. Essentially, the influenza virus damages the respiratory tract and just opens the door for bacteria like Staph aureus or Strep pneumo to walk right in and cause havoc.
And of course, that risk of severe disease is exactly why fast, accurate lab diagnosis is so incredibly important. So back to the lab we go. Today, we have a whole toolkit of molecular methods. Your lab-based RT-PCR is still the gold standard, no question. But these other assays let us tailor our approach, right? We can get rapid point-of-care results in the ER or use deep sequencing for the kind of genomic surveillance that's absolutely essential for tracking that antigenic drift and shift we were just talking about. Now, I know what you're thinking. Viral culture is slow, way too slow for making a clinical decision for a single patient. And you're right. But from a public health standpoint, it is indispensable. We need those live virus isolates to pick strains for the next season's vaccine and to do in-depth drug susceptibility testing. It's still the only way to see how the virus truly behaves in a living system.
And that brings us to susceptibility testing. We really need an integrated approach here. The genotypic assays are fast. They can quickly screen for known resistance mutations. But the phenotypic assays are the confirmation. So you can think of it this way. Genotyping tells you what the virus's genetic code says, but phenotyping tells you what the virus actually does. You really need both for the full picture.
So all this incredible lab data has one primary purpose: to inform treatment. Let's dig into that now, and we'll look at it specifically through the lens of the Dutch guidelines, which are quite interesting.
You can immediately see a difference in philosophy here. The Dutch approach is all about antimicrobial stewardship, a very restrictive, public health-first mindset. The goal is to use antivirals judiciously to minimize the development of resistance. This is in pretty stark contrast to broader international guidelines that really prioritize treating all at-risk individuals as quickly as possible. It's a calculated trade-off, really, trying to preserve our antiviral tools for the long game.
And this difference is even more stark when you look at pediatrics. The Dutch guidelines are very evidence-driven. They argue there isn't high-quality evidence to support routine treatment in otherwise healthy kids. Meanwhile, the American strategy is much more risk-averse, recommending prompt treatment for any hospitalized child or any child in a high-risk group. Two very different ways of weighing risk and benefit.
Okay, so we've talked about treatment. Now let's look at how the virus fights back through resistance, and in turn, how we defend against it using prevention and control strategies.
Resistance, as you know, emerges through mutations in the very protein the drug is designed to target. Adamantines are basically obsolete now because of that S31N mutation. And for the newer drugs like baloxavir, that I38T mutation is a major concern because it shows a really low genetic barrier to resistance. It doesn't take much for the virus to learn that trick.
So how do we stop it from spreading in the first place? Well, it's a multi-layered strategy, guided in the Netherlands by protocols from the LCI. You've got your administrative and environmental controls, your PPE, but the undisputed cornerstone, the foundation of it all, is annual vaccination. It remains our single most effective tool in the fight.
And that brings us full circle. Ultimately, our ability to manage influenza virus, from the vaccine to treatment, depends entirely on constant, vigilant surveillance. And that surveillance comes from labs like yours. You are truly the front line in this ongoing evolutionary arms race.
Which leaves us with a really important question for the whole microbiology community. As the virus continues to evolve, and as we see resistance to even our newest drugs emerging, how do we make sure our surveillance strategies evolve right along with it to stay one step ahead?
That's something we all need to be thinking about, and we hope this review has been a valuable resource for you and your work in trying to anticipate the virus's next move.
For more deep dives like this, please subscribe to the channel. And we'd love to hear your thoughts on that very question in the comments below. Let us know what you think. Thanks for watching.